gestational diabetes, briefly about what is gestational diabetes, how to move forward for the diagnosis of gestational diabetes, and how do you treat the gestational diabetes, and what are the endpoints. Now, a brief introduction. This is diabetes which is diagnosed during pregnancy and which was not an overt diabetes prior to gestation. What does that mean? Because there are two different aspects. Diabetes in pregnancy, and second is pregnancy that occurred in a diabetic patient. Both are different. So this is diagnosed during pregnancy in a patient who did not have diabetes previously. And it affects 2 to 10% of pregnancies globally. And why it is very important is because it impacts both the maternal and fetal health. And the usual period of development of gestational diabetes is usually in the 24th to the 28th week. Now, what are the risk factors? What are the risk factors of which patient do you consider where the gestational diabetes develops? And again, here the important risk factor is the age more than 25 years, an overweight or obese patient, a family history of diabetes, previous gestational diabetes, a mother who had gestational diabetes in previous pregnancy, this nearly has a 100% chance of developing gestational diabetes again, or a large baby in the previous pregnancy, PCOD, and there are certain ethnic backgrounds where there is more prone for developing a gestational diabetes. Now, what are the pathophysiologies of gestational diabetes? Hormonal changes that occur during pregnancy increase the insulin resistance. And when this occurs in a patient who has a propensity to develop diabetes later on, like has insulin resistance, family history of diabetes, and family history of early diabetes, this produces an increase in insulin resistance. The placental hormones also contribute to insulin resistance. And the pancreas cannot produce enough of insulin or excess insulin to compensate for this insulin resistance. Now, what are the signs and symptoms, or how can you say whether the patient can develop gestational diabetes or whether the patient has developed gestational diabetes? Like the other diabetes, most of the patients are asymptomatic. They do not experience any symptom. And this is found during routine testing for diabetes. And here, otherwise, the usual symptoms of diabetes can occur sometimes. That is excessive thirst, that is polydipsia, frequent urination, an amount of fatigue, and sometimes blurred vision. Now, how to diagnose gestational diabetes? There is a routine screening where the patient is screened for gestational diabetes between 24 to 28 weeks of gestation. The age-old glucose challenge test, where you measure the 1 hour glucose after a 50-gram glucose challenge, or a 3-hour OGTT if the glucose challenge test is abnormal. So it can be done as a single approach or a two-set approach. Single approach means you do not do a glucose challenge test. You straight away go for a 75-gram OGTT, that is oral glucose tolerance test. This is performed after an overnight fast between 24 to 28 weeks of gestation. You look at the fasting glucose value, the 1 hour glucose value after giving a 75-gram oral glucose load, and the 2-hour glucose value. And this should be, the fasting should be greater than 92, that is 5.1 millimoles per liter. The 1 hour glucose greater than 180, that is 10 millimoles per liter. And the 2-hour glucose is greater than 153, that is 8.5 millimoles per liter. Now, this is a two-step approach. This is usually done in many places in India, and it is very commonly done in the United States. That is, first you go for a glucose challenge test, and then if the glucose challenge test, you measure a 1 hour glucose after giving a 50-gram glucose load in a non-fasting state. Here, the patient need not be fasting, and you do not need the fasting blood glucose value also. And after an 1 hour glucose, if the blood sugar value after 1 hour is 130 to 140 milligram percentage. Then you proceed to do a 100 gram oral glucose tolerance test. You give a 100 gram oral glucose, the fasting should be more than 95. The 1 hour, 2 hour, and 3 hour values should be 180, 155, and 140 milligram percentage. This is a two-step approach. The previous one is a single step approach. That is, you currently go simply to an OGTT. Now, who all patients or which segment of patients need an early screening? That is, these are the high risk women more prone for developing a gestational diabetes. Consider screening at the first prenatal visit itself in women with obesity, previous history of GDM, gestational diabetes, strong family history of diabetes, and in the initial prenatal visit itself, you can do a fasting plasma glucose and an A1C value. And if needed, you can go for a casual blood glucose or a PPS. Now, how do you manage a case of gestational diabetes? The patient is diagnosed with gestational diabetes in such and such weeks of pregnancy. Now, what do you manage? Like the other diabetes itself, first and foremost, the most important thing is lifestyle modification, which includes diet and exercise. You monitor the blood glucose levels. It is slightly different from the monitoring for the rest of the population when you consider the gestational diabetes. And medications, the preferred medication is always insulin, and you can give oral agents also. Now, the main part, the medical nutrition therapy, that is diet in diabetes, part of lifestyle modification. You have to give a balanced diet, a low GI diet, frequent small meals or snacks because the patient is pregnant, needs frequent nutritions, more chance of hypoglycemia when you start treatment with medications. So frequent small meals and exercise also is very important, even at whatever stage of pregnancy, at least moderate intensity exercise of half an hour walk per day. Then this can also enhance the insulin sensitivity. Now, how do you monitor the blood glucose? It is not like that you monitor in a type 2 diabetes patient. It is more like the monitoring in a type 1 diabetes patient. That is, you have to monitor several times a day, 4 or 5 times a day. You have to monitor in the fasting state, pre-lunch, pre-dinner, 1 hour after meal, 2 hour after meal. And AD has put forward some targets for gestational diabetes, which is different from the target for other diabetes. The fasting has to be much lower than the fasting target for a diabetes patient in gestational diabetes. You have to strictly keep the fasting blood sugar value below 95 milligram percentage for a gestational diabetes patient. This is very important to prevent increasing the weight of the baby, malformations in the baby, hypoglycemia in the baby. So it is to be kept as fasting less than 95 milligram percentage. 1 hour postprandial less than 140 and 2 hour postprandial. That is a conventional 2 hour PPBS less than 120. So fasting less than 95, 2 hour PPBS should be less than 120. Now coming to the drug treatment, insulin oral agents. Why insulin is preferred as the first line always in GDM, or insulin by rule or convention is a standard treatment for GDM as the first line, because of the main issue of insulin resistance due to the placental hormones. Insulin is the most effective and the safest pharmacological therapy. There are no side effects, no harmful effects on the fetus. It does not cross the placenta, very, very important. So, very less chance of fetal hyperglycemia, and it can be used when diet and exercise are insufficient to keep the blood sugar below the target levels. Now, what are the insulins that are approved in pregnancy? There are different types of insulin that are available in the market, short acting analogs, the conventional insulin, the intermediate acting insulin, the long acting, ultra long acting. So many insulins are available. Here, the conventional short acting regular insulin is the one that is used in pregnancy in most of the developing countries. But we have long before started using the Lispro insulin, the Aspart insulin, and even the faster Aspart that is available by the NMPS. All these are approved for use in pregnancy. So these can be given in small doses with small increments based on the blood sugar values. The age-old conventional intermediate acting insulin, that is the NPH insulin, the long-acting insulin, usually the analogs like detimir and glargine. Detimir is approved for giving in pregnancy, but it is no longer available in India, and it's available only in some countries. Glargine insulin, and there are approvals by some agencies, but it is remarkably safe in pregnancy. And those who were on glargine previously have developed, that is diabetes, pregnancy in diabetes can also continue the glargine insulin. The ones that are not approved for pregnancy are the degludec insulin and the glulicid insulin. Now, can you give OADs in pregnancy, or which are the OADs which can be given in pregnancy? There are some sulfonylureas which can be given in pregnancy. Glyburide is the name that is used in Western countries. We use the name glyburide. Metformin is the one drug that is approved in pregnancy. Patients who were taking metformin previously for PCOD or previous diabetes can continue metformin through all the trimesters of pregnancy. It improves the insulin sensitivity, but it crosses the placenta also, but it is remarkably free from any adverse effects to the fetus. And not all sulfonylureas, but some sulfonylureas, old sulfonylureas like glibenclamide, have been approved for pregnancy because it stimulates insulin release. Again, it causes placenta and it has some side effects on the fetus, like sulfonylureas. Otherwise, is also the patient is also more prone for hyperglycemia. Here, the neonate is also more prone for hyperglycemia, and it can produce macrosmia. So, it is ideal if you use an OAD, you can continue with metformin during pregnancy, and you can go with insulin. That is the ideal approach. Now, these are the guidelines by some international bodies. That is, American College of Obstetrics and Gynecology. Here, they prefer insulin itself. Metformin glyburide may be considered. Nice guidelines from UK has accepted metformin as a first line term. So metformin is remarkably safe, though it crosses the placenta. And ADA guidelines always say insulin is preferred, and OAD is only if insulin is not feasible due to some other cause. Now, fetal monitoring has to be more frequent than the routine monitoring in a pregnant lady because the fetal growth has to be assessed, the read for any malformation has to be assessed, the non-stress tests have to be performed in later pregnancy, and you may need to adjust the delivery time if complications arise. And well-controlled gestational diabetes, the timing of delivery is like any other pregnant lady, that is between 13 and 14. See, poorly controlled diabetes or complicated GDM may require an early delivery. Now, what is the management to be continued after delivery? That is immediately after delivery and later. And most of the GDM cases resolve post delivery. You can slowly withdraw the insulin. Sometimes it has to be withdrawn abruptly. The patient develops hyperglycemia. And then the OADs can also be withdrawn. You test for type 2 diabetes, usually at 1.5 to 2 months gap, that is 6 to 12 weeks. And you may need to do a postpartum OGTT in some patients. Otherwise, the straightforward fasting and 2-hour plasma glucose values after 6 to 8 months. 6 weeks to 12 weeks, that is 1.5 to 2 months. You can encourage lifestyle modifications to reduce the future risk of diabetes, because most of the gestational diabetes patients develop diabetes later on at an earlier age than in the general population. And the treatment of GDM, the treatment summaries, it includes diet, exercise, and more frequent monitoring plus medication. And individualized care, like what AD has said in 2024-2025, is individualized care for diabetes. The same with individualized care. It improves the outcome for both the mother and baby, and long-term follow-up is also essential. What are the complications that can occur in the gestational diabetes? The maternal complications are preeclampsia, cesarean, more incidence of cesarean section deliveries, and a future type 2 diabetes. This is more important. Future type 2 diabetes. There will be a macrosmia can occur as a complication for the fetus. More incidence of hypoglycemia in the fetus. There can be respiratory distress, large baby, long-term obesity, and diabetes. And so, glucose testing again have already told there needs to be a long-term risk counseling for the mother and lifestyle advice. Prevention and education. Maintain healthy weight before and during pregnancy. There should be an early screening for high risk women. Educate patients on diet and exercise and glucose monitoring. So, to conclude my talk, gestational diabetes is becoming more and more common, but it is easily manageable. Frequent monitoring, frequent doses of insulin, early detection and management is always the key. Other diabetes also, and long-term follow-up postpartum is also essential. Thank you.